Hypertrophy, disarray, fibrosis, obstruction, and coronary microcirculation in hypertrophic cardiomyopathy. Please, Bill.
So Franco enjoyed that, thank you. And the title of this talk is a bit of a mouthful. This was Yorgos's idea. Hypertrophy, disarray, obstruction, microcirculation. Microcirculation I've actually removed because we don't have enough data. We can only speculate, and spending a lot of time on it is, I think, non-productive. I put in genetics because that's the context, and I've tried to put all of these things, hypertrophy, obstruction, disarray, into the context of diagnosis and management outcomes. So why do we call it hypertrophic cardiomyopathy? Here's the most sensitive test for identifying a patient who has the condition. It's the screening test. It's positive in 95% of patients who fulfill diagnostic criteria. This is something that we can measure, and we understand normality and abnormality. This is a speculative comment. Here's how we diagnose it on imaging, originally M-mode echo, two-dimensional echocardiography, CMR, CT when we don't have good imaging quality. Why do we do this? Is this what the disease is really about, hypertrophy? We do it because we can measure it. What would we really like to know? We'd really like to know the disarray. And this is what Mary and the pathologist can see and measure. Barry Marin did this many years ago and quantitated. Amanda Varnava, working with Mike Davis, has done this and has some disarray in relation to mode of death and underlying genes. I think it's preliminary, it's too small, the numbers, but it seems that the extent of the disarray shown on the right-hand side of the slide actually is associated with sudden death, and it's associated with troponin T mutations in limited data sets. But this is what we would really like to know. Unfortunately, you can't take the heart out, chop it up, measure it, and then put it all back together again. So we're making, when we do risk stratification, we're making indirect measurements of this disarray. And this particular patient was an 18-year-old girl who had normal heart mass, normal heart weight, normal wall thickness, but 40% of her left and right ventricle had this disarray, and she had a troponin T 92 to 95 variant. In terms of diagnosis, the athletic community has thrown up to us the challenge of sorting out the difference between the elite athlete, where the changes in the electrocardiogram, in particular, the autonomic changes, have been published going back almost 50 years. They're very well known to us, and yes, there is a group of elite athletes where the thickening, endurance athletes, where the thickening can overlap with what we see in hypertrophic cardiomyopathy. But in reality, this is a way of producing papers. You should be able to figure out from a family history Q waves and T wave changes on the electrocardiogram. And very importantly, why does an athlete develop hypertrophy? It's a compensatory mechanism in relation to the increased volume, which is there to increase stroke volume and cardiac output. So the hypertrophy is a positive measure. In contrast, in hypertrophic cardiomyopathy, the hypertrophy is at the expense of the cavity. So there's a big difference, and diastolic volumes in the left ventricle. But you should quite easily be able to pull this together from simple tests that we all have. Now, I bring this comes from a very well-known paper by very high-quality individuals in relation to sport medicine. But there's two, this is V3 on the left, 2 athletes, in the middle, 2 hypertrophs, and on the right, ARVC. And the point is made in this paper that when you see this biphasic T wave, if there's J point elevation, that's consistent with racial variant, athletes training, endurance training. Whereas if you don't see the J point elevation in relation to the biphasic T wave in V2, V3, that's consistent with HCM or ARVC. This is the ECG that's in this paper as an example of a black athlete with normal imaging who has these electrocardiographic changes which are attributed to his racial background. And without going into detail, I'd propose to you that this is not a normal electrocardiogram. And I'd like to see the parents and the offspring. So for me, a message in relation to understanding what are we really talking about, we call it hypertrophic cardiomyopathy because we can measure it. But the electrocardiogram is important, and a simple rule for me is an abnormal ECG is an abnormal ECG. And don't write it off as a racial variant, athlete's heart, maybe incomplete imaging, and the athletic community can be drugs, basically, performance-enhancing drugs. The Yorgos's title that he gave me, I think, underscores, and I think I know what he was getting at, is that our perception, cardiologist perception, is that this is a disease of hypertrophy, thick hearts, stiff, diastolic dysfunction, dynamic function associated with turbulence and outflow tract gradient. And that is our perception. That's what we've measured in aficamten and mavacamten trials. This is how we see the disease. I think it's useful looking back, and sometimes to know where you're going, it's useful to look where you've been. And this is a brief summary of hypertrophic cardiomyopathy going back to the beginning with Brownwald and Goodwin and Doug Weigel and others. If you look on the right-hand side of the slide, in the 1960s, this was a disease of obstruction. M-mode echo comes along, and very quickly, early 60s, 64, 65, not all patients have obstruction. In fact, only the minority. And over time, it was for about 25, 30 years, it was about 25%, 25% have obstruction of the outflow tract. So a small percentage. It's changed in the last 10 years, if you will, and it's changed to measuring obstruction post-Valsalva, post-exercise, and now you see reviews where up to 70% of patients with HCM have obstruction. Why is that? Well, for many years we had myectomy to treat this, beta blockers and diazepam. But basically we had myectomy, then we had septal reduction therapies, but now we have new drugs, and we've redefined obstruction in the context of recruitment and other approaches. But I would point out to you that I don't think the patient population, maybe from the 60s is different, but the patient population for the last 30 years is not very different. So we've changed definitions to suit our ability to actually manage, particularly obstruction. In the context of the disarray and risk, again, we're making this on the right-hand side as a list of the things that we know are in guidelines, we know have been established over time. We're not really making a direct measure of what we want to make, what we want to measure, and we've done this. There was fractionation. There's been a variety of approaches, non-invasive and invasive, with electrophysiological approaches to assessment of the inhomogeneity of conduction. None of them have been turned out to be practical. This list on the right, I would say, is pretty much established. There's some controversies in the guidelines, but basically we've used these for a long time. And I think the summary on the left is that if we ask the question, we should ask the question, is this patient at risk of sudden death? If we ask that question and do the risk stratification properly and comprehensively, we can identify the high-risk patient, and we have a treatment or a preventive treatment management program, which is the defibrillator. One of our problems is that even in major referral centers that publish, it's very clear that only that's too strong, a significant proportion of individuals do not undergo 24-hour or 48-hour ECG monitoring, and very few get exercise testing done with comprehensive measurement of the blood pressure response. So we're not doing, we do family history, syncope, and sometimes a Holter, but not much else. So the risk stratification is not being religiously done. Approaches to risk management, they've varied and they've been controversial, but in 2000 we had sort of the risk factors, we put up a score. In 2014 we had the beginning of risk models that we've talked about earlier this morning and earlier today in relation to ARVC. The 2019, and I'll show you data, but Marty Marin, a single center in Boston, very nice paper in relation to one approach which has worked for them. This is how we approach it. This is a 2000-ish paper. And the bottom line here, if you have no risk factors and you do risk assessment properly, no risk factors, you basically don't die suddenly. And you can effectively reassure a patient. If you have 2 or more risk factors, you have a high mortality, and almost regardless of age, you should have a defibrillator. The problem is the majority of deaths occur in the 1 risk factor group. And if you look at the confidence levels, it's 1% per year, but it's 0.2 to 2.2%. So if you put a defibrillator into all these people, the majority of them are not at high risk and will not have an event. So that is our challenge, that's our problem, is how you drill down into that group And yes, individualized therapy, then how do you do that is the question. The risk model approach, the Costas O'Mahony paper, very nice conceptually. And if you just look on the right-hand slide, you've got what's stated in that paper is that we've entered into the model something that appeared in a risk factor that appeared in a multivariate analysis. You'll note there's a couple of important things missing, like gender or sex. And everything we've seen, well, not everything, but the majority of the genes that cause inherited cardiovascular disease has a different outcome in relation to gender. A second one is the absence of an abnormal blood pressure response, and it's stated that's because we didn't have it had not appeared in a multivariate analysis. No, it's by far and away the strongest marker of the low-risk patient. So it identifies people who are safe. It wasn't something we could enter into the risk model because we couldn't reproduce it in other cohorts. So the first model was our own patients. The second was the reproducibility in others, and other people had not done exercise testing in the same way. So it has dropped out. It was in original guidelines, 2 sets of European and American guidelines. It's dropped out as a risk marker. But its main value, you'll note this is risk assessment in HOCM for the high-risk patient. The exercise blood pressure identifies quite accurately the low-risk patient. So if somebody does a maximal exercise test and his blood pressure goes 110 to 180, he is not going to die suddenly. Very, very, very unlikely. If his blood pressure goes 110, 120, 130, 120, he is in a high-risk group. The specificity of that feature is very low. In contrast, non-sustained VT in a adolescent, very low sensitivity, won't pick up the majority, but very specific. So we need to make a distinction between specificity for low risk and for high risk. But the concept of the risk model is a really good one. It's been applied in ARVC. It's a very good, and I think there's a couple, if we can get genetics, if we can get gender into it and some other things, it's an ongoing project that will, I think, bear fruit. Here's what a very comprehensive center, 2,000 patients, Marty Maron, and basically they have put an ICD into anybody with a risk factor, and probably a few that didn't have any risk factors but were concerned. And you'll see it was a 25% implant rate, very high. It's a roughly 2% appropriate discharge rate and a roughly 2% significant unwanted effect from the therapy. But it's one approach, and it's an approach which it's easy to have a different view if you work in a European center. We don't live with the lawyers on top of us. In America, if somebody dies, was there a treatment that you could have done? Yes, a defibrillator. Why didn't you do it? You can't start talking about risk benefit. The trial by jury will side with the patient, and the doctor will be shot. So the contexts are very different, which need to be considered. The other concept, though, or the other important thing is the unwanted effects. So let's just say if you put a defib into a high-risk patient who's got at least one risk factor, you've got about a 2% appropriate discharge rate. You have very significant unwanted effects, and this is a paper from Costas O'Mahony. It's older, but I don't think things have changed that much in terms of the hypertrophy, young hypertrophy, middle-aged hypertrophy is not an easy candidate, nor the ARVC patients, for a defibrillator, and you do get inappropriate discharges and lead complications. The genetics, here we've talked about this. How do we implement the genetics into all of this? Well, this was the first identification in 1990 of a beta-myosin heavy chain mutation. And this led fairly quickly to recognition that this was a disease of the sarcomere, thick and thin filaments, most of the mutations occurring at binding sites between thick and thin filament. Important to recognize that the majority, like that family from Peter Paré and the family that we were able to evaluate 30 years later, every single person who carried the gene had complete disease expression by their late teens. So very easy, abnormal ECG, abnormal echo. Most hypertrophic has age-related penetrance and incomplete disease expression. So that makes, it's a challenge in terms of management, it's a challenge in terms of assessing families and advising families that needs to be considered. I show those slides, which everybody's very familiar with, really to bring up the point that the genetics is changing. And there's the whole emphasis around polygenic risk on the right-hand side of this slide. We're familiar with the terms. We haven't really learned how to apply them, but one of the important aspects of this is that something that we tell all patients is this is genetic. It's usually Mendelian. It's usually, you assume, 50% risk to your offspring. To what extent that is going to need to be modified is not clear, but it is clear that oligogenic and polygenic disease occurs. And for instance, as one example, you can have a myosin-binding protein C deletion, which is autosomal dominant and Mendelian, but you can have a similar mutation, particularly in this a similar mutation, which is actually seen as a polygenic or oligogenic, but it's seen in the normal population, not causing disease, which can actually be implicated in the disease, and that is not Mendelian disease. So to what extent we're going to have to modify remains to be seen. I also point out that when we think of hypertrophic cardiomyopathy, the community tends to focus on the sarcomeric genes, but I just put in 3, but there's actually about 10 regulatory and structural genes, which the majority are Mendelian, but they're important. And 30% of hypertrophs have a gene, only 30% have a mutation identified. Yeah, it depends a little bit, but it depends how you do it. But if you incorporate these between 8 and 10 regulatory functional genes, each one of which is responsible for 1 to 2%, you're up around 50% just incorporating that. So I think the genetics is not a game, set, and match in terms of sarcomeric disease. There's still a lot going on and a lot to be learned, and I think we're going to have to change some of our approaches in relation to management of the family. Obviously, I think this is straightforward. The hypertrophic cardiomyopathy that are associated with syndromes, Noonan, Fabry's, and others, I think we've learned, and I like the analogy that I know when I went to medical school and looking at this list was like memorizing a telephone directory, because it had no meaning. There was no treatment, there were no disease genes, we didn't know anything, it was phenotypes. Here we actually know the phenotypes, we have the genes, and we know a lot of these have specific treatments. So this is part of the spectrum that we deal with, and I think we're fairly increasingly comfortable with that, as recognized by this meeting in many ways. So these genes give us the potential to do something, to actually implement. We have pathogenic mechanisms, we're learning pathogenic mechanisms, and the understanding of these genes is giving us some targets. And 2 things here, just in relation to the genes. One is, to what extent does the knowledge of the gene, is it actionable? Can we do something specific? And then Franco's actually talked about the other is actually, is there a gene therapy? And I'm not going to comment on, well, I won't talk about it because Franco's already spoke about the gene therapy, but in terms of knowledge of the gene, the first gene, myosin, then troponin and tropomyosin, great excitement to genotype, phenotype. When you look back at the Kaplan-Meier survival curves, they were on pathetic numbers of patients. They were small numbers, and we were able to show separation in survival curves, but the numbers were very small, and with greater experience, it became very clear. Actually, not all troponin mutations cause sudden death. Not all myosin mutations were severe. The ones we had identified initially tended to be more severe because of patient selection, and et cetera. But to what extent does knowledge of the mutation get us further ahead in terms of management? Well, these are 4 survival curves, Kaplan-Meier survival curves, in relation to adverse events: sudden death, heart failure, death, transplant. And this is for myosin heavy chain, beta-myosin heavy chain, myosin-binding protein C, troponin T, and troponin I. And statistically, they're very different. But in clinical terms, this is not actionable. But if you look on the lower left, this is 6,000 patients-ish. So this is a decent number of patients from the Health and Code database. And this is reliable data particularly in terms of the genetics and the outcomes. We don't have a lot of phenotype data, but the outcomes are correct. And you would look at this and say, well, this isn't actionable. And I think that's where the community, that's where the guidelines have gotten to. I don't think correctly, but if you drill down and, what do those survival curves relate? Well, that's like saying, oh, all women are this, all men are that. Well, we're all different. And all troponin mutations are not the same. All myosin mutations are not the same. So this is one, and you can do what I'm doing here. You can do it very easily with myosin. I'm not sure with beta-myosin heavy chain. I'm not sure you can do it as well with C protein. But if you take alleles encoding 92 to the amino acids 92 to 95 in troponin T, and this is the survival, the lower survival curve. And if you take alleles encoding the 271, the upper survival curve, they're very different. And if you drill down even further, and the light blue are basically sudden deaths, and the red are basically heart failure related outcomes. If you drill down and look at male versus female, that red line along the top is outcomes in females with a 271. And the lower survival curve is males with the 92 to 95. Well, one has no sudden deaths, and you're not going to consider an ICD, but it's a troponin mutation. The males, basically 40% of them have died suddenly by the age of 50. So knowledge of the specific mutation matters, and you can do exactly the same thing with hinge regions in myosin, etc. So a criticism is we need more data, but definitely there's actionability in this. Another, back to Yorgos's desire to talk about hypertrophy. On the lower left is the slide I showed at the beginning of this girl, 18-year-old girl. I said she's 18, she's 21. No, yeah, she's 21. And in this family, these 4 individuals died suddenly at the ages shown. And the hearts were all sent, the whole hearts were sent to Mary's predecessor, St. George's Michael Davis. And he looked at them and he said, these hearts have normal mass, normal heart weight, there's no segmental thickening, but they all have extensive myocyte disarray. The example I showed you was the worst. And he said, is this some form of non-hypertrophic cardiomyopathy? Until we find the gene, we won't know. The gene is a 92 to it's a 90. The gene is shown above. So this concept of hypertrophy is something we can measure, but I think we need to have a broader view of the disease other than just, because what we tend to do is, 3 centimeter hypertrophy severe. No, not always. 1.4 centimeter hypertrophy doesn't even fulfill diagnostic criteria. Yeah, but there's 4 people here who died suddenly from the condition. So we need a broader and a more open view in relation to this. What have we learned from all this? Well, this is, I think, a neat slide. If you think about myosin cross-bridging, which we're familiar with from the myosin inhibitors now, for argument's sake, a proportion of cross-bridging with wild type is normal, and a proportion with mutant is abnormal. So you'll have different force velocity profiles. Do those different force velocity profiles develop cause the disarray, the disorganization? It's logical. Whether we can't prove that. If you're trying to win the Olympic boat race, or in the context of Oxford-Cambridge, the Oxford-Cambridge boat race, you want the biggest, strongest people you can get, and the universities go recruiting in America from the good universities where there's crew. But more important than how big and strong they are, it's how they row. And if one of these guys is out of sync with the others, if one of them happens to be a mutation rather than what, you'll get disarray, and you'll get the boat tipping over, as happened a couple of years ago in the Oxford-Cambridge boat race. So very important. The homogeneity of contraction is actually very important. And to study this, and this is, when you look at ion channel disease, the first genes that were found for ion channel disease, they had patch clamping, they had models that were easy to study. In hypertrophic cardiomyopathy, you can't go and take a great chunk out of the heart, and small biopsies that we bite are not adequate. The samples you get from myectomy they're scarred and damaged and are not particularly reliable in this context. Beta-myosin heavy chain is expressed in soleus muscle, and a group of German physiologists, Bernhard Brenner, Theresia Kraft, and their team, looked at this. And this is an experiment where they take, when I say a chunk, I mean a chunk of soleus muscle, and they look at skinned muscle fibers. In this particular experiment, there's 19 skin muscle fibers from the controls. Now, very often senior people get promising medical students and young doctors to be the controls. The 3 senior authors on this paper volunteered to have a hunk of their soleus muscle removed. So they are the controls, and you see fairly homogeneous calcium sensitivity curve. They've done they've done a number of the myosin mutations. This is the mutation that is shown here, and you'll see that these curves are shifted to the left, so there's increased sensitivity. So at calcium concentrations that normally develop this force, there's a greater force. But there's some of the fibers were different and actually had a reduced sensitivity. And very curiously, which is hard to interpret, but if you look down at the lower left, where the calcium concentrations are such that you shouldn't have any force being developed there is still a residual force which is significant. Is this, you know, and when we look at hypertrophic cardiomyopathy, we look at a dynamic ventricle that's contracting, and there's a period when there's prolonged ejection time, but there's an inefficient prolonged ejection. And you can say, is this inefficient prolonged ejection, or is it impaired early relaxation? And is it all the same with different mutations? And is this in some way a reflection of what we see and part of the argument in relation to long-standing argument in relation to the significance of obstruction? Speculative. This is of interest because the work of James Spudich, who won a Lasker Prize for developing the laser tweezer. The laser tweezer can take a single myosin molecule and measure the force developed at different calcium concentrations. So this is, if you will, an analog to the work done by Bernard Brenner's team. And you'll see that with some of the hypertrophic mutations, they shift to the left, so there's increased sensitivity. Some of the DCM myosin mutations shift to the right. The work, I'm not that familiar with the DCM, but certainly the HCM work, this was the mutations were selected by Cricket Zeidman. The skill in getting a mutation into a single myosin molecule was Leslie Reinwald, and the laser tweezer was James Spudich. And this actually provides the background to the myosin inhibitors. And one of the things that came out of these experiments is that, you know, we think of the heart contracting and all the muscle fibers are contracting. At any one time, it's about 25% of cross bridges are active. So 75% of the heart is in a resting condition. But in hypertrophic cardiomyopathy, with these myosin mutations, there was an increased number of myosin cross bridges, of active contraction, active cross bridging. Now, one of the questions in relation to the myosin inhibitors, is that just with the myosin, or is that with C protein and others? We don't know. And these experiments are sufficiently complex that you can't just do, well, I don't know this, but I suspect they're not something you can just run a whole batch of them off. So we don't know to what extent other mutations result in a similar increased sensitivity. But we are familiar with all of these studies which are emerging, and the Maverick aficamten story is very clear. An interesting whole issue of Jack recently on aficamten. And usually when you read these trials, you have to sort of go to the addendums to find out individual patient data. Here, you actually can see in this Jack publication the summary data. And this looks at, this is aficamten, myosin inhibitor. It looks at the gradient. The top line is placebo, and the bottom line is active. And you see within 2 weeks of starting treatment, you have an effect on gradient. This is just gradient they're looking at. And by about 4 to 6 weeks, 6 to 8 weeks, you've got the maximum effect, which persists until you stop the drug, and then very quickly you recover back to your resting state in terms of gradient. And this happens to be aficamten because it was easy, it was all in one, but the data from mavacamten is very, very similar. Summary graphic abstract, but basically the top showing increased cross-bridging, on the right with treatment, reduced cross-bridging with the beneficial effects. If we drill down on the beneficial effects, and this I think is of interest. So here on the upper left is patients with a complete response, which, and again, cardiologist response, reduced gradient. So there's complete abolition of the gradient. Again, red is placebo, blue is active. So within 4 to 6 weeks, basically you're getting, none of the placebo patients are getting an effect, or very few of them, and yet you're getting a very strong effect. You're getting rid of the gradient in the majority of patients, and it's persisting. If you move to the right and you look at 50% reduction in proBNP, again, very similar. Within about 4 to 6 weeks, you're getting a dramatic reduction in BNP. And again, that's wonderful. It's a biomarker. So this is the kind of thing that we as cardiologists are interested in, and it reflects many things, as you're aware. But if you go to the bottom part of the slide, is my exercise capacity any better? Well, this is peak VO2. It's a change of less than 1.5, which is basically not very different. Change of more than 1.5 mils per kilogram, which is very modest. That means, yeah, if you were having to stop on the stairs twice, you can get up. Maybe you only stop once now, or you can walk up without. But it's a modest improvement, but statistically different. So this will appear as beneficial in one of the targets to the FDA in getting the drugs approved. And on the right, you see NYHA class, and we all are aware that NYHA works for heart failure. It doesn't work particularly well for hypertrophic cardiomyopathy. And you can be in pulmonary edema on Wednesday night and playing squash on Saturday. Why, we're not sure, but it's not. Whereas if you're in pulmonary edema with ischemic heart disease, you're in pulmonary edema and you're not playing squash on Saturday. So there's NYHA does not capture this, but again, there's a modest improvement in NYHA class. And if you look at other quality of life, symptom status, Kansas City Heart, and the SAQ below, you see fairly, and this is brought down into not worse, no change, small change, modest change, large change, very large change. Yeah, there's a significant difference in patients with a very large change, improvement in these markers of symptom class or status. But there's quite a few patients who not very much happens. And I think, I am emphasizing what cardiologists are interested in, what the FDA are interested, or have been interested. But my point is actually made by someone in the FDA who said, what you're presenting in terms of VO2 and gradient reduction is very nice, but how do the patients feel? And here, the symptomatic status is variable, but in general, there's some patients, and you hear doctors say it's a miracle. I've never seen a patient change like this, and good doctors. So there's clearly something significant in this. Exercise limitation can improve, but this is a key thing for patients. What it doesn't address, nor was it surprised, is just the fear that this disease engenders in many patients for themselves, for their families, and also the guilt. If the best thing you do in life is give the next generation a better chance, and if you think you've passed on a gene that's going to influence the quality of your child's life, you want to shoot yourself, and yet there's nothing that a myosin inhibitor is going to do to fix that. So, but these are other issues that are quite important in the overall assessment of what we're doing in terms of myosin inhibitors, gene therapy. So, in summary, and not to delay the ceremony that's coming up, so some messages. I think first is that good science usually produces more questions than answers, but it also is progress, and I think we've seen that in very slowly over from 1960 roughly to the present, so 80 years or 60 years. The myosin inhibitors, I think we're, given the finances and the amount of money that has to get spent by the companies and the need for a return in terms of selling product, I think we're at the beginning of understanding how these drugs actually work, because they do a lot more than reduce gradients. And you see, so for instance, why do BNPs come flying down with a reduced gradient? Is that just, and the gradient patients are not the ones with the highest BNP. So what else is happening? What's happening to early relaxation? Is there a potential here for treatment of heart failure with reduced ejection, with preserved ejection fraction? We don't fully understand the determinants of success and failure, and this needs to be got into in much more detail. And we need to be getting registries and getting the data, because a lot of for instance, the genetic data is not, apart from your own center, the companies have the genetic data, but that's not been made public at this point. And then I haven't talked, Franco's talked about the gene therapy, but I would very much share his views that if someone had said 5 years ago, gene therapy is on the horizon, I said, you must be joking. But the truth is, and a very nice paper which Franco mentioned, is Barry Greenberg has a New England paper on Danon disease. And if there is a worst form of hypertrophic cardiomyopathy, it's not sarcomeric, but it's Danon. If you're male, you're X-linked LAMP2 mutations. If you're male, you're probably dead of heart failure or suddenly in your 20s. And if you're female, maybe another 10 years. But it's a disease. And in this trial, you're seeing protein-produced resolution of the adverse events, and we'll see whether there's outcomes are prolonged. You've also in the trial had some of the Franco's comments about the immune response are very important, and that's again something that's going to have to be managed. So thank you very much.
Thank you, Bill. Just a very short comment. As someone we treat who is available in Israel, mavacamten, and I can say that I have never seen results in my hypertrophic cardiomyopathy patients like those receiving mavacamten. And I would like to know your opinion, if you would agree on a point you stressed less, is that the type of left ventricular regression, left ventricular hypertrophy regression, and changes in the ECG, positive changes in the ECG, I have never seen before. And I see in these patients, in some of these patients, this would lead us to really think that we are here working on the disease mechanism more, for me, is more convincing than most of the animal data and so on. This practical, at least these 2 points of the LVH regression and improvement in the ECG, which I never seen before.
Yeah, I agree. And you know, the animal data is always exciting. It always worked. We had a grant with somebody from Houston, and everything worked in the mice, and none of the things worked in man. So we know that. And you know, the ECG normalizing. I remember we've been through exercise testing, improving ECGs normalizing after myectomy. We went through a phase after verapamil. There were papers. Basically, never seen this, but we've got to go beyond the anecdote at this point, because it's probably, these are probably correct observations. Why is this happening? How it's happening? We need to dig in to understanding the mechanism, to truly how these drugs are working. And that's you know, this group, you know, Yorgos's young team here with beautiful presentations. That's your challenge, is to figure out what's happening. If we're seeing something good, why?
Yeah. Can I ask to take it one further step? I am convinced that meloxicam improves symptoms, improves perhaps ECG, reduces perhaps hypertrophy after a certain time of treatment. Now, once you stop the treatment, do you have do the symptoms, ECG, and these changes are maintained, or do they revert back to the original? So I know that some of the symptoms come back, but this may be psychological. Objectively, does the ECG or hypertrophy recur? If it does, then perhaps something happens to the mechanism.
Yeah, so I can't remember who it was, but somebody was kibitzing this in one of the earlier sessions about this, suggesting, yeah, but are you just going to do this for life? You're going to keep MAVA or AFA going on for life? And that was the intent of the question, I think, before. I think we do know very quickly, and I showed one of the slides, certainly the gradient comes back within, I think it's about 4 to 6 weeks. So we don't know that, but I'm sure the data on if there's a gradient comes back, I'm sure we know what happened to BNP and other markers. So my semi-ignorant response would be, when you stop the MAVA or AFA, you're going to have recovery of back the way you were, but don't know that.
So you don't fix the problem.
No, no. Only Franco's gene therapy is going to fix the problem.
Okay, thank you very much, Professor McKenna. And now it's my pleasure to introduce Professor Sheppard from the Department of Cardiovascular Pathology, St. George's